Welcome to Roadmap to Residency. In this video, we are walking through high-yield coagulation disorder questions you will see on the Step 2 Clinical Knowledge exam. This is not a traditional lecture. We are focused on test-taking strategy, recognizing classic question stems, and learning how to eliminate wrong answers quickly. If you want to master the underlying concepts, we recommend reviewing the Hematology sections of First Aid for Step 2, as well as the relevant question, banks. Make sure to like and subscribe to this channel and visit roadmap2residency.com to connect with our expert tutors and residency advisors. Let us get started. Here are our learning objectives for today. We want you to walk away able to recognize classic question stems for platelet disorders, coagulation factor deficiencies, hypercoagulable states, and disseminated intravascular coagulation. We will apply a systematic test-taking framework to distinguish between diagnoses that can look very similar in a question stem. You will learn to use buzzword associations and lab value patterns to zero in on the right answer. And we will walk through full multiple-choice questions, explaining every answer choice. For deeper concept review, refer to the Hematology chapters in First Aid for Step 2 and your preferred question bank. The very first step when you see a coagulation question on the boards is to ask yourself, is this a platelet problem or a clotting factor problem? Platelet disorders cause mucocutaneous or surface bleeding. Think petechiae, purpura, easy bruising, gum bleeding, nosebleeds, and heavy periods. Clotting factor disorders cause deep tissue bleeding. Think joint bleeds, deep muscle hematomas, and prolonged surgical bleeding. This distinction alone will help you eliminate half the answer choices on many questions. Then ask whether the presentation is acute or chronic, because that further narrows your differential. For a full review of the coagulation cascade and platelet physiology, refer to your pathology and hematology resources like Pathoma or the First Aid Hematology chapter. Let us lock in the buzzword associations. For immune thrombocytopenic purpura, the board question will show a young woman with isolated low platelets, petechiae, but otherwise normal labs. No big spleen, no anemia, no abnormal white cells. For thrombotic thrombocytopenic purpura, remember the classic pentad. Fever, low platelets, microangiopathic hemolytic anemia, with schistocytes on the peripheral smear, kidney problems, and neurologic symptoms. You do not need all 5 to make the diagnosis on the exam. For heparin-induced thrombocytopenia, the giveaway is a platelet drop greater than 50% that happens 5 to 10 days after starting heparin, and the patient develops clots, not bleeding. That paradoxical thrombosis is the classic board pearl. These buzzwords are covered extensively in question banks, so make sure you are doing practice questions to reinforce these patterns. Let us read through this case. A 25-year-old woman presents with 2 weeks of easy bruising and petechiae on her legs. No recent illness, no medications. On exam, she has petechiae but no enlarged liver or spleen. Her labs show severely low platelets at 18,000, but her hemoglobin and white blood cell count are completely normal. The peripheral smear is unremarkable except for the low platelet count. Before I reveal the answer, let us walk through this systematically. Take a moment and think about what stands out in this stem. Here is the walkthrough. Step 1. Analyze the clues. The absolutely critical finding is isolated thrombocytopenia. Normal hemoglobin means no anemia. Normal white cells mean no marrow failure. No schistocytes mean no microangiopathic hemolytic anemia. In a young woman, isolated low platelets equals immune thrombocytopenic purpura until proven otherwise. Step 2. Eliminate wrong answers. Thrombotic thrombocytopenic purpura requires anemia with schistocytes, fever, and neurologic symptoms, none of which are present. Disseminated intravascular coagulation requires a sick patient with a trigger and consumption of clotting factors. Aplastic anemia causes pancytopenia, meaning all cell lines are low, not just platelets. Step 3, the correct answer is B, immune thrombocytopenic purpura. The board pearl is that this is a diagnosis of exclusion. When they show you isolated low platelets with everything else normal, that is the answer. Review the management algorithm for immune thrombocytopenic purpura in your hematology resources. Case 2. A 32-year-old woman comes in with fever, confusion, and dark urine. Her platelets are critically low, her hemoglobin is low with schistocytes on the smear, her lactate dehydrogenase and indirect bilirubin are elevated suggesting hemolysis, her creatinine is elevated showing kidney injury, and importantly, her coagulation panel is normal. This is a classic board-style question. Think about what combination of findings you are seeing here. What diagnosis explains all of these findings together? And critically, what is the treatment? Let us break this down. Step 1. Recognize the pattern. This patient has the pentad of thrombotic thrombocytopenic purpura, fever, low platelets, microangiopathic hemolytic anemia with schistocytes and high lactate dehydrogenase, renal failure, and neurologic changes. The absolutely critical test-taking tip is that the coagulation panel is normal. In disseminated intravascular coagulation, the prothrombin time and partial thromboplastin time would be prolonged. That normal coag panel is your distinguishing clue. Step 2. Eliminate wrong answers. Platelet transfusion is a classic wrong answer and is actually dangerous here because it adds more fuel for microthrombi. Intravenous immunoglobulin is for immune thrombocytopenic purpura. Heparin is for heparin-induced thrombocytopenia. The correct answer is B, plasma exchange. This is an emergency, and plasma exchange replaces the missing ADAMTS13 enzyme. For a deeper review of thrombotic microangiopathies, check the Hematology section of your Step 2 resources. Here are some critical board pearls about thrombotic microangiopathies. Both thrombotic thrombocytopenic purpura and hemolytic uremic syndrome cause low platelets and microangiopathic hemolytic anemia with schistocytes. The key difference is that thrombotic thrombocytopenic purpura is more neurologic, while hemolytic uremic syndrome is more renal. Hemolytic uremic syndrome classically follows bloody diarrhea from E. coli 0157H7 in children. Treat thrombotic thrombocytopenic purpura with plasma exchange. Treat hemolytic uremic syndrome with supportive care. And never give antibiotics for the diarrheal illness because it can actually worsen hemolytic uremic syndrome. The single most tested lab distinction. In thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, your coagulation studies are normal. In disseminated intravascular coagulation, they are prolonged. This distinction shows up over and over in question banks. Case 3. A 60-year-old man is 1 week out from hip surgery and has been on unfractionated heparin for clot prevention. His platelets have dropped from 250,000 to 85,000, which is more than a 50% drop. And now he has developed a new deep vein thrombosis. This is a critical combination of findings. Think about what the platelet drop timing, the magnitude of the drop, and the paradoxical clotting tell you. What diagnosis fits all of these findings? Let us walk through this. Step 1. Recognize the pattern. The timing is critical. Platelets dropped 5 to 10 days after starting heparin. The drop is greater than 50%, going from 250,000 down to 85,000. And most importantly, the patient developed a new clot while on heparin. This triad, timing, magnitude of drop, and paradoxical thrombosis, is the classic presentation of heparin-induced thrombocytopenia type 2. Step 2. Management. Choice A. Increasing heparin is absolutely wrong and dangerous. Choice C. Platelet transfusion is contraindicated because you are fueling the problem. Choice D. Starting warfarin right away can cause skin necrosis and venous limb gangrene in heparin-induced thrombocytopenia, so you must bridge with a direct thrombin inhibitor like argatrobin first. The correct answer is B. Stop all forms of heparin, including flushes, and start a non-heparin anticoagulant. This management sequence is very commonly tested. Review the heparin-induced thrombocytopenia management algorithm in your board review resources. That wraps up our walkthrough of coagulation disorders for the Step 2 clinical knowledge exam. Let us do a final recap of the key test-taking strategies we covered today. For platelet disorders, remember that isolated low platelets with everything else normal means immune thrombocytopenic purpura. Add schistocytes and neurologic changes with normal coag studies, that is thrombotic thrombocytopenic purpura. Platelet drop after heparin with paradoxical clotting, that is heparin-induced thrombocytopenia. For clotting factor deficiencies, isolated prolonged partial thromboplastin time with joint bleeding in a young male is hemophilia A. For hypercoagulable states, recurrent unprovoked clots in a young patient with family history, think factor V Leiden as the most common inherited cause. And for disseminated intravascular coagulation, everything is abnormal: low platelets, prolonged prothrombin time and partial thromboplastin time, low fibrinogen, high D-dimer, and schistocytes, and the key is to treat the underlying cause. For a deeper dive into any of these topics, check out the Hematology chapters in First Aid for Step 2, Pathoma, and your question bank. Practice questions are the single best way to reinforce these patterns. Thank you so much for watching. Please like this video and subscribe to our channel for more high-yield board review content. And if you want personalized help with your board preparation or residency applications, visit roadmap2residency.com to connect with our expert tutors and residency advisors. Good luck on your exam, and we will see you in the next video.